Welcome to all participants. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Selamat sore. Selamat datang dan selamat bergabung bagi para rekan-rekan, Bapak Ibu, partisipan webinar pada sore hari ini. Acara ini merupakan launching dari Komunitas Fibrosis Paru yang dirangkai dengan acara webinar mengenai fibrosis paru. Komunitas Fibrosis Paru merupakan wadah bagi penyintas, keluarga penyintas, tenaga kesehatan profesional maupun caregiver untuk dapat bertukar informasi dan edukasi mengenai fibrosis paru. Dan saat ini, fibrosis paru merupakan masalah kesehatan yang belum dikenal luas oleh masyarakat di Indonesia, sehingga salah satu misi dari komunitas ini adalah untuk mengkampanyekan fibrosis paru agar lebih dikenal lagi oleh masyarakat Indonesia. Dan jika telah dikenal luas, dampaknya dapat memberikan manfaat bagi peningkatan pelayanan kesehatan untuk para penyintas fibrosis paru. Baik, Bapak, Ibu, rekan-rekan partisipan kegiatan ini, bagi yang tertarik untuk bergabung bersama komunitas, dapat langsung mengikuti sosial media kami, atau langsung masuk ke link registrasi yang sudah disiapkan panitia pada kolom chat. Nah, untuk mempersingkat waktu, telah hadir bersama kita 4 narasumber yang luar biasa yang akan berbagi informasi mengenai fibrosis paru dan komunitas fibrosis paru. Untuk topik pertama pada sore hari ini mengenai apa itu fibrosis paru, topik ini akan disampaikan oleh Dr. Simon Hart. Beliau adalah konsultan respiratory physician pada Interstitial Lung Disease Unit at Hull University Teaching Hospital, NHS Trust, UK. And the speaker already joined us today. The first topic will be delivered by Dr. Simon Hart, consultant respiratory physician at Interstitial Lung Disease Unit at Hull University Teaching Hospital, NHS Trust, UK. Dr. Simon Hart, floor is yours. Kami persilakan kepada Dr. Simon Hart.
Hello and welcome to this talk on what is pulmonary fibrosis. Pulmonary fibrosis describes a range of lung diseases that are characterized by scarring, typically progressive scarring that gets steadily worse over time. So in general, these conditions can be thought of as disorders of abnormal wound healing, since scarring is what our bodies do when trying to heal a wound. And in pulmonary fibrosis, it seems that the wound healing is deranged and out of control. And we'll touch a little bit more on that shortly. But first, after showing my declarations, I thought we'd focus on some of the key clinical aspects that affect patients in terms of pulmonary fibrosis by considering a clinical case typical of a patient who may be referred to my pulmonary fibrosis clinic. So here's the case, a man of 75. His presenting symptom is shortness of breath on walking that's been going on for about a year and getting a little bit worse. Initially, he attributes it to age, lack of fitness, but eventually realizes that something's not right. Past medical history, just high blood pressure, well controlled on medication. He has no other medical conditions. There is no family history of lung disease and no family history of pulmonary fibrosis in particular. That's important. We'll come back to that later. He used to smoke tobacco, but not for quite a long time. He worked as a labourer, so he may have been exposed to certain dusts. He has no pets at home, in particular no birds. The key abnormality on examining him is that when listening to his lungs with a stethoscope, there are fine crackles, very typical of pulmonary fibrosis. So the next thing to do is to arrange an imaging chest x-ray and to refer him on for specialist care. So this is the chest x-ray. This is a chest x-ray showing pulmonary fibrosis, but it's important to consider that in early or mild pulmonary fibrosis, the chest x-ray may well be normal or near normal, and it's the presence of those crackles heard with the stethoscope that is really the key thing that gives the game away, or should make the doctor suspect that there's pulmonary fibrosis. The gold standard imaging technique to diagnose pulmonary fibrosis is a high-resolution CT scan of the chest, performed using a regular CT scanner, but the images are acquired and processed in such a way as to sharpen the edges and allow good definition of the lung tissue and identify characteristic patterns of pulmonary fibrosis as shown here on the right. Often the CT scan will be sufficient to confirm pulmonary fibrosis, but if it isn't, we may proceed to biopsying the lungs through a surgical approach, and the typical pathology of pulmonary fibrosis under the microscope looks like this, with areas of fairly normal lung at the top left with thin alveolar walls, perfect for gas exchange, and then areas of very abnormal pink and blue staining tissue elsewhere, which is the fibrosis, and your eye may be drawn to areas like this, slightly paler blue staining areas, and this is a so-called fibroblastic focus, which is an area of new fibrosis under the epithelium, very characteristic of this type of pulmonary fibrosis. So how do we put this all together in this case to make a diagnosis? Well, we have a multidisciplinary team discussion with the members of the meeting being the clinician, the radiologist for the CT scan interpretation, and if the patient's had a biopsy, then a pathologist. And I would also include blood tests, particularly immunological blood tests under the pathology heading here to be considered to make a diagnosis. And the diagnosis in this case with this patient is idiopathic pulmonary fibrosis, by far the most common but also the most severe and serious form of pulmonary fibrosis that we see. A typical example. So before we come back to this, a little bit about the history of pulmonary fibrosis. So this seems to be a disease that's only really been described in the last 200 years. Here's an early description by the well-known Irish physician Dominic Corrigan, who described what he called cirrhosis of the lung, but he used that word, clearly it's normally applied to the fibrotic liver, to describe the stiff fibrotic lung that he observed in patients with pulmonary fibrosis. And then we have to fast forward to the later part of the last century, really, to understand more about pulmonary fibrosis. And one of the key figures there was the American pathologist Avril Liebau, who described the pathology of fibrotic lungs as shown here on the right-hand side. And he recognized the shrunken, scarred, so-called honeycomb lung with these cystic areas within it that was characteristic of pulmonary fibrosis. And he coined a number of the terms that are still in use today, such as usual interstitial pneumonia, UIP, to describe this characteristic pathology. So with that in mind, let's have a little summary of what is idiopathic pulmonary fibrosis. Well, it's typically a disease that affects older people and typically presents like our patient did in our case scenario, with gradually worsening shortness of breath and possibly a dry cough. The key clinical features, the crackles, finger clubbing, the radiological features, fibrosis on X-ray and CT scan, although we don't usually do a lung biopsy because we think we're pretty good at predicting the pathology of fibrosis by looking at the CT scan patterns. In the UK, we think there are about 15,000 cases, but it's difficult to get precise figures, but we're pretty clear that it's increasing in prevalence. Idiopathic pulmonary fibrosis, idiopathic meaning of unknown cause, means that other conditions associated with pulmonary fibrosis have been excluded. So it is a diagnosis of exclusion, and we'll come back to that a little bit later on when we touch on other conditions that are linked to pulmonary fibrosis. This very strict definition of IPF is useful for clinical trials, and indeed there's been a huge expansion of clinical research in pulmonary fibrosis in recent years and decades. But IPF is really the prototype now for a range of pulmonary fibrosis conditions that we would put under the umbrella term of progressive pulmonary fibrosis. We'll touch on that a little bit later as well. Well, how does it happen? So we've got an abnormal, persistent, progressive wound healing response. What's going on there? Let's consider then the anatomy of the normal lung, where air is taken down into the lung tissue through the airways, about 15 divisions and then subdivisions, right down to the alveolar air sacs right at the bottom. So these are these tiny little balloons, each the width of a few human hairs. There are about 300 million of them in the human lungs, and together their combined surface area is over 100 square meters, which makes them perfect for gas exchange, which of course is a key function of the lung. Let's zoom into one of these single alveolar air sacs, because that's where the problem lies in pulmonary fibrosis. And here's a diagram, and we've really got three components here. We've got the air and the alveolus, we've got the blood in the pulmonary capillaries, and in between we have this little thin section of tissue that we call the lung interstitial, and that's where the problem lies in pulmonary fibrosis. And pulmonary fibrosis is encompassed by the broader term of interstitial lung diseases, because that's the part of the lung that's affected. Let's zoom into that a little bit more closely and have a look at what's normally in the interstitium. And normally in the interstitium, there are a few cells called fibroblasts, and their function is to produce a protein called elastin, which is what gives the lungs their stretch. The lungs are like balloons. They inflate and then deflate passively due to the elastic tissue within them produced by the fibroblasts. So what about in pulmonary fibrosis? Let's remove some of these for clarity. So what happens in pulmonary fibrosis is that something drives these fibroblasts to have a wound response, a wound healing response, and they proliferate. And they not only proliferate, but they start to lay down a different protein, collagen, which is like a cement that glues up the lungs. It's stiff and it fills up the interstitium. And this process proceeds, the interstitium widens. There are more fibroblasts, some of them a bit like muscle cells like this, and they lay down more cement collagen. So eventually we end up with a situation that looks like this on the right compared with the healthy lung on the left, where there's a widened, thickened interstitium full of scar tissue and cement, which makes the lung stiff, and it lengthens the path between the air and the blood, and that leads to impaired lung function. So that's what seems to happen, but why does that happen? And that's the great unknown, and the thing that we need to understand much better if we're going to develop better treatments. But let's just look at one hypothesis of why pulmonary fibrosis happens. And to do that, we just need to consider more of the cells that might be around. And there are various cells in the airway, like macrophages, big eating cells, and there are immune cells in the blood. And all of these cells can communicate with the fibroblasts to initiate or to start off that abnormal wound healing response if appropriately triggered. And of course, there may be crosstalk between these different cell types, leading to that abnormal wound response. So many of these cell types may be involved, but let's just focus on one, and that's the green epithelial cells, which line the air-containing airspace here. And the function of these cells is to replicate and replenish and regenerate the lining of the lung, and they do that throughout a person's lifetime until they can no longer do it. because they've aged, they've become senescent, a phrase meaning premature aging. And these cells can no longer divide and replenish. They become larger, but they don't die, they persist. And almost like a cry for help, they release chemical mediators that act on the neighboring fibroblasts that are able to then stimulate those fibroblasts to initiate that wound healing response and that scarring within the lung. So it seems that cellular senescence, premature aging, is a key driver of lung fibrosis. And we can certainly see these senescent cells in the lungs of people with pulmonary fibrosis, and we can model the process in the laboratory. Here's some research that my PhD student did, where she took lung lining cells on the left-hand side that were normal, and then she stimulated them to undergo senescence in the right-hand panels, and they enlarge, as seen at the top, and they stain with a blue stain, as shown at the bottom, indicating that these are senescent. So this means that we can study this process in the laboratory, and hopefully as a result then understand excuse me, more about the biology of pulmonary fibrosis and how we may be able to manipulate that with future drug therapies. This is relevant in the clinic because many of the risk factors for pulmonary fibrosis predispose to cellular senescence, premature aging. So aging of the person themselves, a family history of pulmonary fibrosis may be because of abnormalities in genes that predispose to cellular senescence, and a person's prior inhalation of smoke or dust or asbestos fibers may also lead to these cells becoming senescent prematurely. We touched earlier on IPF, and we mentioned that there are other types of pulmonary fibrosis as well, and this is something that people are very interested in. And I'll put up a slide here that shows a kind of medical classification of other types of pulmonary fibrosis. The details are probably not that important, but on the left-hand side, we've got diseases of known cause, or I prefer to say known association, because I don't like to list these really as causes necessarily of pulmonary fibrosis. So we know that people with connective tissue disease or rheumatic diseases like rheumatoid arthritis or systemic sclerosis, scleroderma, are at much higher risk of developing pulmonary fibrosis. These are autoimmune diseases, but the fibrosis is not necessarily autoimmune, and it doesn't respond very well to the anti-inflammatory immune modulating treatments that people with rheumatoid or scleroderma are typically treated with. So there may be a different connection there. Further down on the left-hand side, inhalation of certain dust, and that includes bird dander, so-called hypersensitivity pneumonitis, can lead to a fibrotic type of disease. Inhalation of asbestos fibers can lead to asbestosis, which is a form of pulmonary fibrosis. And at the bottom, we've got some drug therapies, but they're pretty rare. Well, on the right-hand side, then, if we've excluded these known causes or association, we're left with the idiopathic diseases, of which by far the most important is IPF at the top there. But there are some others that can look rather similar and behave in a similar way, which I've listed there. The details, as I say, are not that important, and I'll explain why now. So if we look at these diseases as a whole, they actually encompass a spectrum. From, on the left-hand side, diseases of the lung interstitium, which are characterized mainly by inflammation, that is potentially reversible. It could go back to normal, either by itself or with anti-inflammatory drug therapy, such as steroid therapy. In contrast, on the right-hand side, we've got the diseases like IPF, where there is irreversible and progressive worsening fibrosis, which doesn't respond to anti-inflammatory therapy, but we may be able to slow it down with an antifibrotic drug. So diseases like IPF are always irreversible and progressive, but some of these other conditions, which I've listed just a few of them for simplicity here, can demonstrate a whole range of different behaviors, from a very benign course that gets better by itself or with treatment, to a progressive pulmonary fibrosis that behaves essentially identically to IPF. So these are the conditions that we're worried about over on the right-hand side over here, IPF and the diseases that can behave just like it, which could be any of those conditions. And as I said, there are more. I've just shown some of them here for simplicity. So it may not matter so much what the disease is. IPF, rheumatoid pulmonary fibrosis, hypersensitivity pneumonitis, if it behaves in a progressive fibrotic manner like this. So these are CT scans 4 years apart on a patient of mine. And on the right-hand side, there is progressive fibrosis, and you can see this honeycomb change with the cystic appearance of the lungs, which is very characteristic. So regardless of what we call this, this is progressive pulmonary fibrosis. And if disease behaves like that, then in a way, all these conditions are actually very similar. So there's been a move from separating the different conditions and labeling with different labels to lumping, if you like, conditions together if they have the phenotype of progressive pulmonary fibrosis, because they should be then addressed and managed in the same way. The drugs that we have available for IPF, 2 approved drugs in pirfenidone and nintedanib, probably have similar effects in slowing down the fibrosis in a range of pulmonary fibrosis conditions. And this was actually confirmed with nintedanib in a big clinical trial called InBuild. And this is very similar to IPF data, where we've plotted here over 52 weeks, 1 year, hundreds of patients who were treated either with nintedanib in the dark blue or placebo, dummy, in the light blue. And this is decline. This shows their decline in lung function as measured by lung function tests and a measure of vital capacity over 52 weeks. And nintedanib slows the rate of decline. So the antifibrotic drugs do not make pulmonary fibrosis better, but they are disease modifying and slow down the rate of progression over time, as demonstrated here. And there are numerous other trials that show similar effects. Currently, in the UK, pirfenidone and nintedanib are licensed for IPF, and nintedanib alone is licensed for other types of non-IPF progressive pulmonary fibrosis, but the approvals differ from country to country. That's drug therapy, but I wanted to finish by highlighting that effective care of patients with pulmonary fibrosis encompasses many different things other than drug therapy. And I've tried to illustrate these on this slide here. From the top left, the information and support provided by charities like Action for Pulmonary Fibrosis. The vital importance of clinical trials of new experimental drugs, of which there are many in development, which is very encouraging. The importance of support groups of patients, considering lung transplantation for suitable people, the provision of home oxygen for people who are persistently hypoxemic, the importance of breathlessness management either through pulmonary rehabilitation, specialist breathlessness clinics, and all the use of drug therapies such as low-dose opioids. And in the middle here, the most important person in terms of coordinating that care for the patient, who is the interstitial lung disease specialist nurse, a vital cog in the machine and a vital member of the most vital member of the team. There are many more things that we could talk about in terms of pulmonary fibrosis, but I hope I've given you a little overview there. And I think we will have an opportunity for questions and answers shortly. Thank you for listening.
Thank you, Dr. Simon Hart, for the concise and excellent explanation about pulmonary fibrosis. And now we'll proceed to the next topic. The next topic will be delivered by Dr. Gina Amanda. She is a pulmonologist and founder for Pulmonary Fibrosis Community. The topic will be Pulmonary Fibrosis Community in Indonesia and why it is important. Kita akan berlanjut ke topik selanjutnya, yaitu mengenai komunitas fibrosis paru di Indonesia, mengapa hal tersebut menjadi penting, dan topik ini akan dibawakan oleh Dr. Gina Amanda. Beliau adalah spesialis paru yang berpengalaman dalam menangani pasien fibrosis paru, dan sekaligus sebagai founder dari Pulmonary Fibrosis, komunitas Fibrosis Paru. Kepada Dr. Gina Amanda, dipersilakan, Dok.
Terima kasih, Dr. Prima. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, good evening for all of you who attend our webinar and launching Pulmonary Fibrosis Community. Pada hari ini, saya diberi kesempatan mewakili dari pengurus Komunitas Fibrosis Paru untuk mempresentasikan tentang Komunitas Fibrosis Paru di Indonesia dan mengapa ini menjadi penting untuk ada di Indonesia. So, my topic is Pulmonary Fibrosis Community Indonesia. Why is it important? Fibrosis paru seperti yang sudah dijelaskan oleh Dr. Simon Hart tadi, bahwa adalah kondisi paru yang menjadi keras dan kaku sehingga menyebabkan terjadinya gangguan pertukaran gas di paru. Seperti yang kita lihat pada gambar di sebelah kanan, bahwa paru, yaitu tadi ada alveolus atau kantong udara yang bagian terkecil dari paru pada kondisi normal, bentuknya bagus dan bisa menyebabkan terjadinya pertukaran gas antara oksigen dan karbon dioksida dengan baik dari sisi paru ke darah dan sebaliknya. Namun pada kondisi terjadinya penyakit paru interstitial atau interstitial lung disease (ILD), rongga atau daerah interstitium tersebut menjadi lebih tebal sehingga sulit untuk terjadinya pertukaran gas. Fibrosis paru itu sendiri sebenarnya merupakan bagian dari payung penyakit paru interstitial atau ILD. Jadi dia adalah bagian dari penyakit paru interstitial yang jumlahnya sekitar lebih dari 200. Secara garis besar, penyakit paru interstitial tersebut dibagi atas penyakit paru yang idiopatik, kemudian yang disebabkan oleh penyakit autoimun, hypersensitivity pneumonitis, sarkoidosis, dan jenis-jenis lain dari penyakit paru interstitial. Namun, pada semua atau bagian-bagian dari klasifikasi ini tidak semuanya adalah penyakit fibrosis paru. Yang termasuk fibrosis paru adalah antara lain idiopathic pulmonary fibrosis, kemudian idiopathic SIP, penyakit paru yang karena autoimun antara lain adalah systemic sclerosis ILD, rheumatoid arthritis ILD, kemudian unclassifiable IIP, kemudian juga hypersensitivity pneumonitis, sarkoidosis, dan penyakit ILD yang disebabkan karena janan di tempat kerja. Pada kejadian fibrosis paru, ini memang suatu yang sulit untuk kita prediksi, terutama di Indonesia. Sementara untuk di Amerika Serikat sendiri, insidensnya adalah sekitar 30 kasus ILD per 100.000 populasi per tahun, dengan insiden untuk yang IPF, yang idiopatik, itu 3-9 kasus per 100.000 populasi per tahun. Tadi untuk di UK, Dr. Simon Hart juga menyebutkan bahwa ada 15.000 kasus IPF di UK. Nah, sebenarnya ILD sendiri masuk klasifikasi penyakit yang jarang atau rare disease. Walaupun demikian, tidak berarti bahwa jarang itu sedikit. Bisa saja mungkin dia jarang karena kita kurang mengenalinya atau mengalami masalah dalam diagnosis pasien tersebut. Dari 200 lebih tipe ILD tadi, bahwa ada beberapa tipe yang sering dijumpai, antara lain IPF atau yang idiopatik sebesar 20%, kemudian yang kronik hypersensitivity pneumonitis 20%, yang karena autoimun juga 20%, sarkoidosis 20%, dan tipe lain serta pneumokoniosis itu masing-masing 10%. Dari klasifikasi yang banyak tadi, bahwa paling banyak justru memang dalam bentuk yang fibrosis, IPF, chronic hypersensitivity pneumonitis, kemudian yang karena autoimun, sarkoidosis, dan pneumokoniosis itu sebagian besar adalah bentuk-bentuk yang fibrosis paru. Fibrosis paru terjadi antara lain karena ada faktor risiko yang diderita oleh seorang pasien, bisa karena pajanan lingkungan ataupun faktor pajanan lainnya, faktor genetik, ataupun aktivasi sistem imun, sistem daya tahan tubuh yang berlebih. Dan inisiasi terjadinya ILD terjadi di kemudian hari itu antara lain karena pencetus yang persisten, artinya seperti faktor lingkungan tadi menjadi terus-menerus terpajan ke dalam tubuh pasien, atau karena penyakit sistemik, misalnya penyakit autoimun, karena skleroderma atau systemic sclerosis, rheumatoid arthritis, dan penyakit autoimun lainnya, atau ada infeksi dan juga proses aging atau penuaan. Dan tadi juga Dr. Simon menjelaskan bahwa akan ada dua macam atau dua tipe bentuk dari ILD ini sendiri. Ada yang sifatnya inflamasi, fibrosis, ataupun campuran keduanya. Kalau dia dalam bentuknya inflamasi atau peradangan, maka biasanya sebagian besar akan resolusi atau perbaikan. Dan untuk yang fibrosis ini justru yang kondisinya makin lama makin berat karena akan terjadi progresif. Artinya semakin lama kondisi pasien bisa semakin menurun karena penyakitnya cenderung bertambah berat berdasarkan waktu. Sedangkan yang campuran biasanya masih bisa persisten dan untuk menjadi progresif itu lebih lambat. Bagaimana proses paru itu didiagnosis, antara lain mengikuti beberapa prosedur seperti yang wajib dilakukan adalah high resolution CT scan thorax atau CT scan dada tanpa menggunakan zat kontras. Dan ini biasanya untuk diagnosis ILD sendiri perlu protokol khusus karena akan berbeda dengan CT scan biasa. Misalnya pada pasien tumor atau pasien yang dicurigai ada keganasan, maka bagaimana prosedur untuk ILD itu akan berbeda karena memerlukan protokol khusus. Misalnya perlu ada pengambilan gambar pada saat pasien inspirasi dan ekspirasi, artinya ketika pasien mengambil nafas dan membuang nafasnya. Jadi ada protokol khusus untuk melakukan high resolution CT scan dada pada pasien yang dicurigai untuk diagnosis ILD. Kemudian yang lain adalah pemeriksaan tes fungsi paru, yaitu dengan menggunakan spirometri ataupun di LCO, serta pemeriksaan tes fungsi paru lainnya. Kemudian melakukan biopsi ataupun pemeriksaan BAL. BAL itu adalah pemeriksaan sel dari cairan saluran napas, dan prosedur pengambilannya bisa melalui bronkoskopi atau mungkin teropong ke saluran nafas, juga dengan menggunakan pendekatan bedah. Pemeriksaan lain adalah pemeriksaan imunologi, misalnya untuk pemeriksaan darah. Tadi juga Dr. Hart menjelaskan bahwa prosedur yang dilewati pasien antara lain ketika dia datang ke dokter, kita dari dokter sendiri mesti mengetahui bagaimana riwayat dari pasien, berapa lama perjalanan penyakit atau gejala yang dialaminya, kapan mulai terjadinya, kemudian apa saja pajanan yang mungkin muncul selama kondisi tersebut, kemudian riwayat pengobatan, riwayat penyakit dalam keluarga, terutama riwayat penyakit fibrosis paru, kemudian juga penyakit penyerta yang mungkin menyertai sudah ada diderita pasien sebelumnya. Kemudian juga dilakukan pemeriksaan fisis oleh dokter, baik dengan menggunakan stetoskop, sehingga bisa dengarkan ada bunyi tambahan pada bunyi nafasnya. Kemudian pemeriksaan darah, pemeriksaan radiologi tadi seperti mungkin untuk awal adalah pemeriksaan fototoraks atau ronsen dada, yang gambarnya mungkin saja awalnya adalah normal, namun kalau kondisi normal tersebut pada ronsen dada, apabila di pemeriksaan fisisnya ditemukan ada kelainan, maka biasanya tetap dilanjutkan dengan pemeriksaan radiologi lain, yaitu pemeriksaan high resolution CT scan. Kemudian juga pemeriksaan fungsi paru. Kemudian dari data yang sudah dikumpulkan tadi, maka bisa dilakukan multidisciplinary discussion atau diskusi multidisiplin. Di sini ada dokter paru sebagai klinisi, kemudian dokter radiologi, dokter patologi. Pada kasus yang lain juga mungkin disertai dokter reumatologi, dokter bedah toraks, dokter rehabilitasi medik yang bisa mendiskusikan bagaimana diagnosis atau tindakan prosedur diagnostik yang akan dilakukan ke depannya, dan juga terapi pasien. Apakah pasien akan dilakukan biopsi secara bedah atau melalui bronkoskopi, pemeriksaan BAL, atau pemeriksaan lainnya, juga apakah nantinya pasien perlu diberikan terapi baik itu antifibrotik ataupun imunosupresan, atau justru dia lebih masuk ke kandidat untuk dilakukan transplantasi paru. Kemudian terapi fibrosis paru itu cukup kompleks, tidak hanya meliputi pengobatan pasien saja, bukan berarti hanya memberikan obat seperti imunosupresan ataupun antifibrotik sesuai dengan kondisinya, tetapi juga terapi berbagai macam hal. Misal terapi gejala, apakah kondisi sesak ataupun batuknya yang perlu diobati, kemudian pemberian oksigen, yaitu untuk pasien-pasien dengan gagal nafas kronik, sudah ada tanda gagal nafas kronik, maka dia sudah bisa masuk untuk diberikan atau kandidat untuk diberikan terapi oksigen jangka panjang, rehabilitasi medik, kemudian juga life care, kemudian dukungan psikologis dan spiritual, dukungan teman dan keluarga. Kemudian yang lain adalah bagaimana pasien itu bisa mendapatkan informasi yang tepat dan akurat sesuai dengan kondisi penyakitnya, juga mendapatkan diagnosis yang cepat, tepat, dan akurat, kemudian meningkatkan awareness atau kesadaran pada pasien dan keluarga serta orang-orang di sekitarnya, dan tentunya juga bagaimana pasien dapat menemui dokter yang sesuai dengan kondisi penyakitnya. Untuk prognosis pasien fibrosis paru secara prognosis artinya perjalanan penyakitnya biasanya lebih buruk justru dibandingkan pasien kanker, namun sebagian besar datang kasus dengan kondisi yang lanjut dan banyak faktor lain juga yang mempengaruhi, misalnya ketersediaan obat ataupun diagnosis yang lebih awal, sehingga ini juga mengganggu prognosis pasien ke depannya. Bagaimana di Indonesia? Sampai saat ini kita di Indonesia belum ada data pasti berapa jumlah pasien fibrosis paru, kemudian tingkat kesadaran atau awareness dan pengetahuan tentang fibrosis paru juga masih belum baik. Keterbatasan dalam prosedur diagnostik baik akses, artinya mungkin pasien di satu daerah mesti berpindah atau pergi ke daerah yang lain untuk mendapatkan prosedur diagnostik yang tepat, dan juga dari segi kuantitas, artinya fasilitas diagnostik yang masih terbatas di berbagai wilayah Indonesia, dan jikapun fasilitas itu ada, kualitasnya mungkin juga masih belum baik. Kemudian keterbatasan dalam terapi, baik itu akses dan juga coverage asuransi, kemudian keterlambatan diagnosis yang tinggi, artinya sebagian besar pasien datang sudah dalam kondisi yang berat, dan juga sering terjadi misdiagnosis, artinya pasien sering salah atau mungkin prediksi awalnya bukan fibrosis paru, sehingga kadang pasien sudah mendapatkan terapi misalnya tuberkulosis ataupun bronkiektasis. Hal ini tentunya akan memperlambat diagnosis fibrosis paru pada pasien itu sendiri. Kemudian kami di sini mendirikan suatu komunitas, yaitu Komunitas Fibrosis Paru, dengan tujuan atau visi adalah meningkatkan kesadaran dan pengetahuan masyarakat Indonesia tentang penyakit fibrosis paru. Misinya yang pertama meningkatkan awareness, artinya kesadaran tentang penyakit fibrosis paru di kalangan pasien, dokter, tenaga medis, dan masyarakat, melakukan edukasi tentang penyakit fibrosis paru baik bagi pasien dan keluarganya ataupun masyarakat melalui social media campaign, video, kegiatan webinar, patient meeting online ataupun offline, sehingga pasien dan keluarga mendapatkan informasi yang tepat dan benar mengenai fibrosis paru. Yang lain adalah menjadi wadah berbagi informasi dan dukungan antara anggota komunitas, kemudian meningkatkan edukasi penyakit fibrosis paru di kalangan medis, baik training ataupun peer group discussion, kemudian melakukan kolaborasi dengan komunitas dan yayasan lain yang erat kaitan dengan fibrosis paru. Sampai saat ini kami didukung oleh EU-IPFF dan Action for PF dari UK, dan juga yayasan ataupun komunitas lain yang ada di Indonesia, antara lain Yayasan Skleroderma Indonesia dan Indonesia. Kemudian mendukung perbaikan kemampuan diagnostik untuk penyakit fibrosis paru, termasuk dibentuknya tim multidisiplin yang bisa berdiskusi mengenai diagnosis pasien, sehingga hal tersebut bisa diakses antar rumah sakit ataupun daerah. Mendukung upaya pasien mendapatkan terapi yang sesuai dengan penyakitnya, dan mendukung penelitian serta riset terkait diagnosis dan tata laksana fibrosis paru. Saya mewakili pengurus pada hari ini resmi meluncurkan Komunitas Fibrosis Paru pada tanggal 18 September 2002, dan dari pendiri komunitas ada 3 dokter paru, antara lain Dr. Atit, Dr. Prima, dan juga saya. Kemudian sampai saat ini pengurus antara lain adalah Dr. Anissa Sutra, pulmonologis, kemudian Dr. Atit, Dr. Prima, saya, dan juga Mbak Jennifer dan Mbak Yanci dari pasien. Kemudian komunitas ini didukung oleh European Idiopathic Pulmonary Fibrosis and Related Disorder Federations dan Action for Pulmonary Fibrosis di UK. Pada kesempatan ini saya juga dari pengurus mewakili pengurus menyampaikan terima kasih yang sangat banyak atas support dan dukungan serta saran dan berbagai macam hal yang diberikan kepada kami, antara lain kepada seluruh pasien fibrosis paru dan keluarganya, juga kepada Mr. Steve Jones. Mr. Steve Jones adalah Presiden EU-IPFF. Saya pertama kali berkontak dengan beliau di tahun 2021 setelah acara EU-IPFF Summit 2021. Pada saat itu mungkin belum ada cerita tentang komunitas dan memang komunikasi juga agak terhambat terkait COVID yang sedang banyak. Namun setelah kita bertiga waktu itu memang berencana membuat komunitas fibrosis paru dan saya mengkontak beliau kembali dan beliau banyak memberikan support dan juga termasuk untuk acara ini memberikan ide dan support bagi kami. Dr. Simon Hart atas kuliahnya hari ini, dan tadi beliau sudah hadir, mungkin sedang keluar sebentar. Kemudian Dr. Dianiati dan Dr. Sita, dokter spesialis paru yang juga banyak memberikan dukungan dan saran bagi terbentuknya komunitas. EU-IPFF, Mr. Liam Galvin, CEO dari EU-IPFF, dan juga Ms. Luz Reich, CEO dari Action for PF UK, yang sebelumnya saya juga sempat bertemu beliau. Kemudian seluruh dokter paru di Indonesia, Dr. Andika, Dr. Salma, dan yang banyak membantu sharing dari komunitas fibrosis paru di Instagram, di sosial media, dan juga semua rekan-rekan dokter paru seluruh Indonesia yang banyak memberikan support baik langsung ataupun via WhatsApp, dan juga seluruh dokter di Indonesia, Dr. Susan, dokter spesialis bedah toraks, kemudian Dr. Indah Citra neurologis, dan seluruh dokter yang teman-teman sejawat dokter yang mensupport kami, juga rekan-rekan perawat dan petugas medis lainnya juga yang banyak membantu acara, Miss Putri, Miss Reska, dan Miss Lia. Sampai saat ini, Komunitas Fibrosis Paru ada 52 orang yang telah bergabung bersama kami, 30 diantaranya pasien fibrosis paru. Komunitas ini terbuka bagi siapa saja yang tidak hanya pasien dan keluarga, tapi siapa saja yang tertarik untuk mengetahui lebih lanjut tentang fibrosis paru, termasuk dokter, nurse, dan juga tenaga medis lainnya. Untuk link registrasi bisa di-scan barcode-nya. Jadi bagi pasien, jangan berjuang sendiri tentang penyakit Anda, bergabunglah bersama kami. Dan untuk informasi komunitas bisa diakses di sosial media, Instagram, YouTube, Telegram, Twitter, dan bisa email in person ke komunitasfibrosisparu@gmail.com atau bisa kontak saya di Instagram Indonesia_ILD. Dan kami harapkan ke depannya komunitas ini, komunitas fibrosis paru, bisa lebih banyak berkiprah, lebih banyak membantu pasien, dan kondisi kita menurut Steve adalah kondisi 20 tahun yang lalu di UK, dan kami harap kita juga bisa mengejar apa yang sudah tertinggal dibandingkan yang lain. Saya mewakili seluruh pengurus mengucapkan terima kasih atas kehadiran teman-teman pasien dan keluarga, kemudian dokter, profesor, ataupun perawat, serta seluruh hadirin yang datang pada acara hari ini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, good evening. Saya kembalikan ke Dr. Prima.
Terima kasih Dr. Gina, presentasi yang sangat informatif sekali dan semoga bisa membuka wawasan kita semua mengenai pentingnya komunitas fibrosis paru. Thank you Dr. Gina for the excellent information. Now we proceed to the next topic about Pulmonary Fibrosis Patient Organization in Europe, what we do and why. The topic will be delivered by Mr. Steve Jones. He is a president of EU-IPFF and a chair of Action Pulmonary Fibrosis in UK. Mr. Jones, floor is yours. Acara selanjutnya yaitu presentasi dari Bapak Steve Jones. Beliau adalah presiden dari EU-IPFF dan ketua dari Action for Pulmonary Fibrosis di UK. Tema yang akan dibawakan oleh beliau yaitu mengenai pulmonary fibrosis paru dan organisasi pasien di Eropa. Apa yang sudah mereka lakukan dan mengapa. Silakan.
Hello, everybody. Thank you very much for inviting me to take part in your meeting today. And it's a real pleasure to be here. My name is Steve Jones. I'm the president of the European Pulmonary Fibrosis Federation, EU-IPFF, and I'm also chair of Action for Pulmonary Fibrosis, which is the leading patient organisation in the UK. As well as that, I'm a patient. I was diagnosed with idiopathic pulmonary fibrosis, IPF, in 2008, and I lived with the disease for 8 years until, as I was getting really quite sick in 2016, I was very lucky to be given a single lung transplant. And as you can see, 6 years later, I'm still here, which I'm really good. It means I can do a lot to continue to advocate for patients living with pulmonary fibrosis. Your meeting today is a very important meeting. We've done a lot in Europe, in the UK and Europe and other European countries. We've done a lot to raise awareness of pulmonary fibrosis and to begin to improve treatments and care of patients. But we've only been going now for less than 10 years, and there's so much more to do. I really firmly believe we've got to develop a global network of national patient organizations in all the countries of the world to give voice to the PF patients' concerns. This has got to be a global effort, and your meeting today is an important step towards that. I'm going to talk about two things today. I'm going to talk about the EU-IPFF, the European Pulmonary Fibrosis Federation, and then I'm going to talk about Action for Pulmonary Fibrosis, describe why we exist, what we're trying to achieve, and what progress we have made so far. So the talk then is called Patient Organizations in Europe. And the first presentation, EU-IPFF, an overview of the organization, the European Pulmonary Fibrosis Federation. The first thing to say is that we are a membership organization. We were established in 2016. We initially focused on people living with IPF, idiopathic pulmonary fibrosis, but now we deal with any patients living with any form of progressive pulmonary fibrosis. We are a federation of 22 pulmonary fibrosis patient organizations from 15 different European countries. We operate, as I said, as a member organization. An annual general meeting each year elects an executive board of 7 people, which in turn elects the president on a 2-year term. And I'm currently in my second and final 2-year term as president. We're funded largely by pharmaceutical companies. They either become sponsors, in which case they make a contribution towards our overheads, or they fund the specific projects where we have a shared interest. Our income is approximately $400,000 a year. The aim of EU-IPFF is to promote the rights of patients living with the disease across Europe. And when we say Europe, we mean the whole of Europe, not just the European Union, but including other countries not members of the Union, like the UK, Southeast Europe, Eastern Europe, indeed Russia, and Belarus, and countries like that as well. So we advocate for sustainable improvements in the quality of life and survival time of those living with progressive pulmonary fibrosis. We aim to be and to present a united pulmonary fibrosis patient voice for people living with the disease in Europe, to raise awareness, to educate healthcare professionals, to campaign for improved treatments and care, and funding and facilitating research. Our goals are briefly to promote access to accurate information. You'll see from our website, we have a lot of information on the website which is available for patients. We advocate for the rights of patients and carers, and involving patients in decisions about their healthcare and about research. We argue for improving access to and improving services, and this can be both pharmacological, nintedanib, pirfenidone, it could be the antifibrotic drugs. It can also be non-pharmacological, including pulmonary rehabilitation, psychological care, etc. Number 4, facilitate information exchange and collaboration among relevant organizations in Europe and around the world. We foster collaboration with scientists and with experts and medical societies. And very important for today's talk, we support the establishment of patient associations in countries where they currently don't have some. And this can include strengthening organizations where they exist, but they're not yet strong enough. Our program of work for the current year for 2022, are firstly our main activities. We have a benchmarking report we've produced and updated over the last few years, which is an indication, a snapshot of the treatment of pulmonary fibrosis patients in all the countries who are members of EU-IPFF. And this year we'll be increasing it up to 15, 16, I think maybe even 18 countries we'll be covering, and saying against a number of criteria, how well does each country do in meeting the treatment needs of pulmonary fibrosis patients. We put a lot of effort, the second box here, a lot of effort in the last couple of years into developing a cadre of patient advocates in each of the countries we work in, capable of lobbying and campaigning within their own country with their own governments to improve healthcare for pulmonary fibrosis patients. We've had 8 graduates of our program so far, and we're planning to expand that over this year and future years. The blue box is very interesting because for many years we've been involved at the request of pharmaceutical companies. We go to meetings where we advise them on topics they want to ask us about. So they may have a clinical trial coming up. They want us to ask about the design of that clinical trial, so which is great. And we're very pleased and very happy to do that. That's an important part of our work. But what we're doing now is we're turning the table and we're saying to pharmaceutical companies, okay, we're very happy to have answered your questions. Now, these are our questions. These are the questions which patients are putting to us. Can we please have a meeting where you answer our questions instead? And the first of those meetings is to take place shortly with one of the major pharmaceutical companies, and we have another 2 planned for the next year. So very important development, these community advisory boards. Fourthly, we have a whole webinar series. You'll see these is in English and with subtitles later into other European languages. The webinars take place every 4 to 6 weeks, and these are designed to lead up to the 2nd European Pulmonary Fibrosis Patient Summit, which will be held in 2022, not 2024 as it says here, where we are, and I'll talk a little bit more about that in a moment. But a hugely important event that we are funding for, that we are organising for the 2nd time this year. And then in 2024, we're going to hold a face-to-face meeting. The meeting this year is virtual. And lastly, but by no means least, we put a lot of effort every year. As probably you know, September is Pulmonary Fibrosis Month. Throughout the world, it's the global month when we all highlight pulmonary fibrosis, try and get it in the media, try and educate doctors and others about the disease. We have in the middle of a very successful campaign this year. We've already started to plan our campaign for 2023. This is a very important part of what we do as a federation. So we have links across Europe with relevant medical and scientific congresses. We have a clinical trial finder on our website. You can click to find out what clinical trials are going on currently in Europe. We partner with a whole range of organizations, anything that we can do, and particularly with those undertaking research projects to try and improve the lives of pulmonary fibrosis patients and to involve them in decisions about their treatment and in decisions about research. And as an example, then I said the Pulmonary Fibrosis Patient Summit this year will be the 2nd summit of its kind that we've run. The last one in 2021 was also a virtual summit. Brings together patients, carers, professionals, policymakers, and industry representatives to discuss a range of themes around person-centered care, policies, patient advocacy that are relevant to patients. And last time we're hoping this year anyway, that we'll have in the region of 500 to 600 people participating. It's taking place over 2 to 3 days. It'll be a virtual meeting. Sessions will be on a range of different topics. You can see some of them on the website, our website now, if you go to them. Webinars, roundtables, there'll be symposia. It's going to be a really excellent event. And for any of you who feel comfortable in listening in English and taking part in English, please do come along to the second European Pulmonary Fibrosis Patient Summit from the 3rd to the 5th of November this year. Great. Well, that is EU-IPFF. I think we've achieved a lot over the we've only been in existence now for about 8 years. We have developed a patient charter for pulmonary fibrosis patients in Europe, which we're in the process of updating. We have done, as I said, a lot of work on research, our own research, and working with universities and research institutes and pharma companies to make sure the patient voice is there. And I've talked about both the clinical trial finder and the awareness campaigns. So we've done a lot, but my word, there's a great deal more that we have to do. And we look forward to working and partnering with other organizations around the world and in Indonesia, where we can hopefully do things even better by working together. Now, excuse me, turning now to Action for Pulmonary Fibrosis. As I said, EU-IPFF has about 22 member organizations. Action for Pulmonary Fibrosis in the UK, which I'm the chair of, is probably one of the leading organizations in Europe. It's been going now for 9 years. And in that time, it's grown rapidly and it continues to grow rapidly. Very active patients, carers, and also the clinicians involved in interstitial lung disease in the UK are very much involved in supporting our work. Our vision in APF is to find a cure for pulmonary fibrosis and ensure that everyone affected by the disease has a better future. So this is about helping patients to meet what they support them now in the short term, campaign for better treatment for them, but fund and support and facilitate the research that hopefully will bring about a cure. We've done a lot of thinking about what our values are. The first and most important is that we are patient-led or patient-driven. We empower patients, and patients are at the heart of everything we do. We don't introduce a new or design a new program without first discussing it with groups of patients. We don't go to a meeting with pharmaceuticals, without a patient being present. So patients are at the center of everything we do. We hope we're a caring and compassionate organization that understand and respect patients and carers and can help them get the support they need. We strive for excellence in everything we do. We try to be as open and approachable as we can. And we're ambitious. Frankly, we are ambitious to do more and do better for people living with pulmonary fibrosis. And we're prepared to be bold in the way in which we do that. We're in the middle of a 3-year plan at the moment. And there are 4 main areas of here I'd like to talk about. The first is research, trying to find better treatments and a cure faster. Now, we all know that a cure for pulmonary fibrosis is probably a long way off. Despite very rapid advances in genetics and in understanding microbiology and all the processes involved in fibrosis, honestly, it'll be 10, 20 years before we begin to find a treatment which can really stop the disease in its tracks, which we might begin to think of as a cure. But we're doing an awful lot to speed that process. We have 2 research fellowships coming to an end now, one on the genetics of IPF, another one on, on bacterial and viral load in the lungs. Both of those have come up with path-breaking findings, which should lead to improvements for patients in time. We're currently have a call out for applications for 2 new fellowships that we hope to launch next year. But in addition to actually funding research ourselves, a very important part of what we do is to facilitate the research of others. So we are very big on patient and public involvement in research. If a pharmaceutical company or a research institute or a university undertaking a major piece of research on pulmonary fibrosis needs to meet patients, wants a patient view on the design of the trial, wants a patient view on the materials that they're going to give to patients taking part in the trial, we will organize that and we will facilitate it. We see our role increasingly as a facilitator of the body of research going on towards finding a cure for pulmonary fibrosis. A second thing we're very much involved in is education. One of the main problems throughout the world, but certainly throughout Europe, is that diagnosis is slow. People are diagnosed with pulmonary fibrosis far too slowly, and they're often misdiagnosed. To help in this, we've, for example, got with the Royal College of General Practitioners in the UK, we've developed a web learning platform for GPs, primary care doctors, to go online, do the course, takes about an hour, and to really update their knowledge on what is pulmonary fibrosis. And we do various other things for nurses and other healthcare professionals too. On campaigns and awareness, we have a national conversation going on at the moment involving patients, carers, and healthcare professionals, saying to ourselves, what can we do to improve the treatment of pulmonary fibrosis patients, care and treatment of pulmonary fibrosis patients in the UK? And we're campaigning to improve the service provided by the National Health Service. So 3 very important areas. But the fourth is the one that really motivates and drives us, I can say, speaking for myself personally, which is to make sure that families living with pulmonary fibrosis are better informed and well supported. We do this in a whole range of ways. We do it through information posted online and sent via email and post. We have people who can phone into a helpline to get advice from a nurse. We have people who can act as buddies for people who are living on their own, finding life very difficult. We can arrange a buddy for them who understands what it is to live with pulmonary fibrosis and can provide support. But most important for me under this heading is pulmonary fibrosis support groups. We had, before COVID struck, 75 pulmonary fibrosis support groups that were meeting every 1 or 2 months in 75 different locations across the UK. Our ambition before COVID was to increase this to 100 so that no patient would have to drive for more than an hour to get to a pulmonary fibrosis support group. These groups are so important. They are areas where you can go to improve the information you get, both from the talks that are given by healthcare professionals, but also by talking to other patients, and where you can find mutual support, where you can support fellows, patients and families living with the disease, and they also can get support. And this is a major, major emphasis of what we do. We've changed a bit with COVID. Most of this takes place now on Zoom. But as COVID begins to recede, we're beginning to have face-to-face meetings again as well. So hugely important for us is the whole question of support and support groups. And this is a picture of two friends of mine, actually, from the Papworth support group in Cambridge, who said the group has created a community that meets together where people can discuss their feelings, experiences, and can get top tips on what to do to manage living with pulmonary fibrosis. It has a wonderful positive feeling, and many members who take part have become firm friends over the past few years. So this is one group. I could give you another dozen or 20 groups that are really active and where patients themselves run the support groups with the support of doctors and nurses. So support groups, very important, and I hope many of you will be thinking about how you can develop those within different parts of Indonesia. And finally, research is a major thing we've done, but just to show how we do it slightly differently, is that within our support groups, we are identifying people to train as research champions, patients or carers who are interested in research, who are trained to learn more about it, and can then facilitate the relationship between local support groups and doctors and researchers doing research. And it's proving hugely successful. And we have got it, I think it's in about 12 or so at the moment, research champions, but we're going to be double that number this year. And this program will continue to grow. So there are many new ways we can think about how we can do best for people living with pulmonary fibrosis. So I think what I hope I've got across to you is the idea that we are young. EU-IPFF, 7, 8 years old. Action for Pulmonary Fibrosis, 9 years old. We've achieved a lot in that time, both organizations. We have much to be proud of. But so there's an awful lot more to do as well. And if I can just show you finally that to show that APF is an organization from the beginning which brings together patients. In this picture, the gentleman on the left and me on the right are both patients. It brings together some of the top doctors in the UK, Simon, who you've heard from today already, Gisley Jenkins from Imperial College, Helen Parfrey from Cambridge, and there are carers who have lost family members to the disease. Wendy and Elizabeth here, on this side next to me, and over here, these two new trustees, both have lost their parents to the disease. So we are strong, we are patient-driven, but to be involved in our board of trustees, our board of directors, you have to be either a patient, a carer, or a clinician working with pulmonary fibrosis patients. We are of patients and we are for patients. So as I said, we've achieved a lot in the time. Let's now, all of us around the world, work together to raise our voice globally for pulmonary fibrosis patients and to cooperate together as we do that. Now, I've recorded this, so I'll be very happy to take questions because I'll be online as well. Thank you very much indeed for your time. Thank you.
Thank you very much, Mr. Steve Jones, and welcome, Mr. Steve Jones. We are very glad to having you here. Very outstanding information. And now we'll proceed to the last session. Presentation about patient voice that will be delivered by Jennifer. Topik selanjutnya pada webinar kali ini adalah suara pasien yang akan disampaikan oleh Mbak Jennifer. Kepada Mbak Jennifer, kami persilakan.
Terima kasih, Dokter. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore semuanya. Perkenalkan, nama saya Jennifer. Saya di sini mewakili teman-teman pasien fibrosis paru dari Komunitas Fibrosis Paru. Saya sendiri memiliki berbagai penyakit kronis dan berbagai riwayat penyakit lainnya. Untuk penyakit fibrosis paru saya sendiri ini masih sedang dalam tahap observasi, dikategorikan ke yang mana. Dan seringkali juga sesak napas saya itu timbul karena ada miastenia gravis saya sendiri. Dan mungkin bisa next slide. Nah ya, ini saya beberapa kali masuk IGD dan berkali-kali dirawat juga karena sesak napas. Saya sendiri di rumah ada tabung oksigen, alhamdulillah, dan ada alat pengukur saturasi oksigen. Jadi begitu saturasi turun, saya langsung pakai oksigen di rumah. Kalau tidak membaik, baru ke IGD begitu. Dan mungkin bisa next slide. Jadi sebagai seorang pasien ya mewakili teman-teman yang lain, saya rasa kami butuh penjelasan yang jelas dari dokter yang menangani kami sebelum dan setelah ditegakkannya diagnosis penyakit. Karena sebelum ditegakkannya diagnosis penyakit kan ada proses anamnesis, ada proses pemeriksaan seperti rongsen, CT scan, dan sebagainya, itu kan panjang prosesnya. Nah, seringkali justru sebelum diagnosis ini tegak itu lebih menegangkan dibanding setelah diagnosisnya tegak. Dan seringkali kecemasan juga muncul, dan ketika kecemasan dan kebingungan itu muncul, yang pasien lakukan adalah bertanya kepada Google atau bertanya kepada pasien-pasien lain yang mungkin pernah mengalami pengalaman serupa gitu, atau bertanya kepada teman gitu ya, pokoknya mencari tahu sendiri itu, mencari tahu sendiri, ini saya begini, ini kenapa gitu, nanti saya akan di CT scan ini nanti gimana ya gitu. Itu nah harapannya sih ya untuk semua nakes nantinya, bahkan sebelum ditegakkan diagnosis, kalau bisa dijelaskan nanti kita pemeriksaannya ke arah penyakit A, B, C. Nanti akan ada pemeriksaan namanya CT scan. Nanti prosesnya begini. Kalau penyakitnya A, berarti pengobatannya ini atau treatmentnya ini. Gitu. Kalau penyakitnya B, berarti pengobatannya ini. Gitu. Nanti kelanjutannya seperti ini. Dan untuk proses setelah diagnosisnya pun, kalaupun tidak ada harapan, kan nanti juga kalau kondisinya sudah parah banget, kan juga ada kerjasama dengan pihak spesialis jiwa, ya ada juga penyakit dalam psikosomatik yang juga kerap membantu gitu untuk memberi edukasi kepada pasien, terutama terkait regulasi emosi dan proses penerimaan begitu. Lalu yang kami harapkan juga adalah kejelasan gitu, kejelasan tentang penyakit ini apa sih gitu, penyebabnya apa gitu, karena saya sering kali saya ikut banyak komunitas ya, karena saya memiliki banyak penyakit kronis, saya mengikuti banyak komunitas, ada myasthenia gravis, Sjogren's syndrome dan lain-lain. Itu ada banyak kasus pasien itu bertanya di grup karena penjelasan dari dokter yang merawat juga kurang jelas gitu, dan bahkan men-share ulang hasil lab, hasil CT scan gitu yang dia dapatkan, di-share ulang ke grup gitu, lalu ditanyakan ulang gitu karena kekurang jelasannya itu. Nah, kami berharap adanya kejelasan gitu, dan kalaupun butuh dirujuk ke fasilitas kesehatan yang lain ya monggo dirujuk ke fasilitas kesehatan lain untuk didapatkan penjelasan yang lebih lanjut lagi gitu. Lalu yang kami butuhkan selanjutnya adalah kami butuh tahu kalau kami ini tidak sendirian. Tentunya komunitas ini sangat membantu ya, komunitas sesama pasien, komunitas keluarga pasien, itu sangat-sangat membantu. Jadi merasa tahu kalau kita nggak berjuang sendirian aja, itu sudah sangat membantu. Gitu. Kita semua tidak ada yang tahu usia kita bersisa berapa lama, tapi setidaknya kita bisa fokus pada apa yang bisa kita lakukan di sisa usia kita gitu. Dan kalau bisa kita mau memaksimalkan apa yang bisa kita lakukan di sisa usia kita. Dan tentu kita butuh informasi yang valid dan reliable gitu ya. Jangan mengandalkan Google, karena kalau mengandalkan Google atau mengandalkan bertanya ke sana ke sini, ujung-ujungnya nanti jadi target marketing, dan karena ada banyak kasus, misalnya ada yang pasien sharing di sosial media tentang penyakitnya apa gitu, lalu keluhannya misalnya sesak napas, lalu ada yang menjawab ke pesan itu di media sosial, diberi informasi tentang produk ABC gitu. Dan ternyata setelah dikonsumsi terjadi perburukan Dan setelah sekian lama ternyata ada dokter yang menginformasikan di Instagram pribadi beliau maupun suatu organisasi menyatakan bahwa produk tersebut ternyata justru bisa membahayakan pasien karena ada kandungan ABCD-nya, dan itu justru berbahaya bagi kondisi pasien dengan penyakit ABC begitu. Yang itu pun ada kasus pencatutan nama, jadi diklaim dokter A membolehkan mengonsumsi produk B karena bisa diklaim mengobati penyakit ABC gitu. Padahal dokter tersebut tidak pernah menyetujui menjadi brand ambassador atau mempromosikan produk tersebut gitu. Tapi ternyata namanya dicatutkan gitu, dan ada juga nama selebriti yang dicatutkan dalam promosi produk tersebut, dan jadinya memakan korban gitu. Dan ini sangat berbahaya gitu di kalangan pasien gitu, jadi korban marketing, keluar dana banyak karena produk-produknya tidak murah, dan akhirnya malah terjadi perburukan penyakit. Itu sangat berbahaya. Jadi wadah seperti ini itu bisa jadi sarana bagi pasien untuk bertanya, kalau beli produk ini aman tidak ya gitu untuk kami penderita misalnya fibrosis paru atau penderita penyakit autoimun tertentu gitu. Jadi sebelum membeli bisa bertanya dulu kepada tenaga kesehatan maupun teman-teman di komunitas gitu, dengan diberikan informasi yang valid. Dan juga informasi-informasi terbaru ya, kami tentunya butuh informasi terbaru karena dunia medis ini kan selalu berkembang, jadi kita butuh diinformasikan kalau ada riset terbaru, ada pengobatan terbaru, lalu ada terapi terbaru, dan apapun yang terbaru, kami kalau bisa ada harapan baru untuk kami yang ingin hidup lebih baik, kami ingin tahu. Dan yang terakhir yang kami butuhkan sebagai pasien adalah support. Support di sini dari banyak pihak ya tentunya. Dari keluarga, dari dokter yang merawat, dari pemerintah, dan fasilitas di sekitar kita juga tentunya ya. Ini yang saya sayangkan, saya sedih sekali di negara kita ini, Indonesia ini masih, bahkan di kota besar seperti Jakarta pun, ini masih banyak tempat-tempat yang tidak ramah disabilitas. Bukan banyak lagi, bahkan sebagai orang yang dengan banyak penyakit kronis ini juga seringkali bingung gitu kalau mau berpergian. Ada banyak kasus teman-teman dari sesama pasien yang pulang dari rumah sakit, lalu dalam perjalanan pulang itu harus dilarikan lagi ke IGD karena eskalator di stasiun keretanya mati. Eskalator di stasiun keretanya mati, lalu harus naik tangga dan kambuh, sesak napas gitu. Ini tentu menyedihkan ya untuk kita semua. Jadi kami berharap ada support dari pemerintah terkait ini. Dan support dari BPJS tentunya, dan semuanya. Baik, itu saja dari saya. Mohon maaf atas kekurangannya. Saya ucapkan terima kasih. Saya kembalikan kepada Dr. Prima.
Thank you, Jennifer, for this information and for the experience as a patient for lung pulmonary fibrosis. Terima kasih Mbak Jennifer atas sharing informasinya. Semoga lebih banyak lagi penyintas fibrosis paru yang bisa bergabung pada komunitas ini dan menyampaikan aspirasinya. All of speakers already join us today. It's an honor for us having an excellent speaker, and we are appreciate to the discussion session. And I will invite participants who want to ask can write down the question on the chat box. And here we already have some question. The first question addressed to Mr. Steve Jones. The question is, in Indonesia, antifibrotic drugs and other medication for the lung fibrosis is not covered in health insurance yet. Maybe you have an experience. How did EU-IPFF or Action for PF advocate the government to approve antifibrotic and medication for lung fibrosis? Please,
Great, thank you. Great, well, thank you very much indeed. It's a pleasure to be here this morning. I noticed that my colleague Simon Hart, Dr. Simon Hart, has joined as well now, so that's great. So you can take all the difficult questions, Simon. The question, I mean, what you raise is an issue which is a problem in many countries, especially developing countries around the world. These expensive drugs become available and they're not easily, they're too expensive often for health systems to put forward. We have the similar problems even in the UK now. One of the two antifibrotic drugs is not, well, neither of the drugs is fully available to all patients for all forms of pulmonary fibrosis. And we have had a long battle. I mean, we've been battling as Action for Pulmonary Fibrosis in the UK for five or 6 years. I'm personally optimistic that within a year we will have cracked it and these two drugs will be available. But in all the other, most of the other European countries, they are fully available and they're reimbursed under insurance or the medical system of the country or whatever. The problem you have, I think, is to provide evidence. And one of the problems we have with pulmonary fibrosis, and it's a way, the question that comes later from Wahoo Subetki as well, is about the fact that pulmonary fibrosis is a relatively uncommon disease. It's not a rare disease when you look at it, all forms of pulmonary fibrosis, but it's uncommon. And just as the other gentleman says, the trouble is all the radiologists in Indonesia, they only see TB when they look at a CT scan. Well, it's a similar sort of problem that, you know, bureaucrats sitting in ministries of health only see COPD, they see asthma, they see TB, they don't see pulmonary fibrosis. So we have to create the evidence. And I think we'd be happy to work with you to try and create the evidence on how many patients there are who have pulmonary fibrosis in Indonesia, what the impact of that is on them and their families, what the economic impact is on the society. And we need to produce the strong economic and policy arguments for why the drug should be covered. And I think you will find now a lot of changes happening. I'm sure that the pharmaceutical companies are very flexible in their pricing policies. One of the drugs, pirfenidone, is now off-label, which means you can buy generic versions of the drug from, say, from India or one of the countries that also manufactures it quite cheaply. There's lots we could do, but I think we need to work together to do that. Yeah? And we'd be happy to do that.
Thank you, Steve. Jadi untuk pertanyaan pertama, tadi menurut Steve ada beberapa hal yang perlu dilakukan. Yang pertama, kita menyediakan bukti-bukti klinis terkait dengan pasien IPF sebagai dasar untuk mengajukan obat kepada pemerintah. Data-data tersebut meliputi jumlah pasien, dampak ekonomis yang ditimbulkan akibat penyakit ini. Baik, the second question will be to Dr. Simon. The question is, This is from Mr. Ali. He asking about, is there any medication for lung fibrosis? He has been diagnosed pulmonary fibrosis because of COVID in 2021. Please, your explanation, Dr. Simon.
Thank you. So the question, if I heard correctly, was about drug treatment for pulmonary fibrosis
Caused by COVID infection, post-COVID infection.
Fortunately, COVID infection has not led to an epidemic of lung fibrosis that we were concerned about at the beginning of the pandemic. Some people who have had severe COVID infection requiring admission to hospital or admission to an intensive care unit have been left with some lung scarring, fibrosis, damage. But fortunately, it does not turn into a progressive form of pulmonary fibrosis like IPF. And in fact, generally after COVID, if you have lung fibrosis after COVID, it often slowly improves rather than get worse. So that's good news. And in that respect, no antifibrotic drug treatment is required. The patients who we have seen who have worsening pulmonary fibrosis after COVID probably had a disease like IPF beforehand that wasn't realized or wasn't recognized, which has become apparent since the person had a CT scan, for example, because they had COVID. So there are a few people in whom the fibrosis seems to be post-COVID, but they probably had something like IPF beforehand. And that requires some deliberation and consideration from the specialist, doctor, to work that out. So generally, I'm not worried about post-COVID fibrosis, but it is important to make sure that that's definitely what it is and isn't something like IPF. I hope that answers the question.
Thank you, Dr. Simon. Jadi pertanyaan kedua tadi dari Bapak Ali, apakah ada terapi untuk fibrosis paru, khususnya fibrosis yang disebabkan karena COVID, karena beliau didiagnosis sebagai fibrosis paru akibat COVID di tahun 2021. Jadi jawaban dari Dr. Simon tadi bahwa untuk fibrosis paru karena COVID itu tidak menjadi progresif, jadi tidak berkembang menjadi lebih berat, tidak berkembang menjadi lebih buruk. Itu hal yang menggembirakan, berbeda dengan fibrosis paru yang lainnya, sehingga kemungkinan untuk bisa dapat disembuhkan. Demikian. Next question will be addressed to Steve again, Mr. Steve Jones. The question is, how did EU-IPFF or Action for PF start their collaboration with ILD or Respiratory Center?
Yeah, that's very interesting, actually, because in both organizations, it came from the very beginning. It was a partnership of doctors, carers, and patients. The driving force behind the first meeting in the UK, Simon, correct me if I'm wrong, but I think it was Professor Gisley Jenkins, who's now at the Imperial College in London, was then at the University of Nottingham. He, together with Dr. Helen Parfrey at Cambridge, had a meeting where they invited patients, carers, other people interested in pulmonary fibrosis, just for a discussion. What can we do? It's a little bit like the meeting you're having today. You know, everybody coming into a room and saying, what can we do about this? And from that, we started Action for Pulmonary Fibrosis. And similar things was happening in other European countries. So 2 years later, the same approach was done again, where we got all the different organizations together. I think there are only about 8 to start with in Europe, and said, what can we do in Europe? What do we need to do and how do we do it? And again, it was a partnership of doctors, other healthcare professionals, patients and carers. I mean, EU-IPFF, we have a scientific advisory board of and I think it's now 25 to 30 of the leading interstitial lung disease experts across Europe on there advising us. So we have somebody from every country where we have a member organization. In the UK, we have 3 leading doctors, or 2 now, on our board of trustees. And we have, well, you know, I can pick up the phone now to almost any one of the ILD leads in the country because we're well known, we're trusted, we partner with the top doctors, and they're really are part of our work. I mean, I don't know, Simon, if you want to add to that. It's a very valuable two-way partnership.
Yeah, I completely agree, Steve. And it's mutual trust, isn't it? It's both ways. The pulmonary fibrosis specialists in the UK very much trust APF and what the charity is done and what it's doing, and they're very happy to have that two-way relationship. And it's it just, you know, it's about, as Steve says, it's about starting that up and then developing that over time. It's not going to happen overnight, but there has to be a start.
Thank you, Dr. Simon and Steve Jones. Pertanyaan ketiga tadi terkait dengan bagaimana EU-IPFF atau Action for PF memulai kolaborasi dengan RS. Jadi menurut Dr. Simon dan Steve bahwa dalam membangun kerjasama itu tidak dalam waktu yang singkat, tidak dalam waktu yang semalam. Jadi untuk EU-IPFF membutuhkan sekitar 2 tahun untuk kemudian membuat organisasinya menjadi lebih besar, untuk kemudian bekerja sama dengan banyak profesi kesehatan, organisasi lain. Dan tambahan dari Dr. Simon tadi adalah perlu dibina hubungan baik antara tenaga kesehatan dan kemudian anggota komunitas, dan kepercayaan ini nanti yang akan membesarkan organisasi. Baik. Next question is addressed. Sorry. The next question addressed to Dr. Simon. The question is, okay.
Shall I? Is this the one from Wahoo?
Yes.
Yeah. I'll quickly put it for Simon.
Okay,
he's saying. Shall I describe it? He's saying, Simon, basically, you know, TB is so dominant in Indonesia that do you think this fact will make it more difficult and challenging to diagnose, screen, and treat pulmonary fibrosis? Because everything on the radiography will be suspected to be TB until you prove otherwise. So that's the question.
Yeah,
good question.
I'm glad you can see the questions, Steve, because I can't see the questions. Am I missing something? But
you can see them on chat if you click the chat box at the bottom. Yeah.
I've got that, but I'm not. Anyway, it doesn't matter. I shall answer your question. Yeah, absolutely. On a chest X-ray, which would be the first way of looking at the lungs, it will be difficult to distinguish TB from other types of interstitial lung disease or pulmonary fibrosis. Possibly a CT scan of the chest would be quite good at distinguishing, to be honest, because TB is a disease that tends to affect the top parts of the lungs in a certain sort of way, kind of different from most other types of pulmonary fibrosis. So it depends, and you guys, Prima, you can tell me, on access to CT scanning, I guess, in Indonesia. So how easy is it for a patient to get a CT scan of their chest? That's what it depends on.
Here in Indonesia, not every hospital has a CT scan. So usually is the CT scan already in a district hospital, that quite big hospital. So in the remote or rural area is not available there. So it's one of difficulty for us to diagnose lung fibrosis.
Actually, maybe another problem is we can treat patient as clinical tuberculosis when we look at the chest X-ray with massive infiltrate, and then we give the patient or prescribe the patient with anti-tuberculosis drug for the treatment. Actually, the patient is not tuberculosis, but maybe they are pulmonary fibrosis patients. So it's the problem why the patient become delayed diagnosis for PF here. I think for this case, for pulmonary tuberculosis patients who were diagnosed as clinical tuberculosis, when we give the treatment for 2 months for anti-tuberculosis drug, and there is no improvement, it's a time for us to refer the patient for HRCT scans patient. So don't delay patients, don't delay the diagnosis, because it will be related to the prognosis of the patients itself. I think that's I can answer about this.
Any other comment, Dr. Simon Hart?
No, thank you, Gina. That's I completely agree with you. And just to emphasize, when it comes to tuberculosis, you guys are the professionals at that, and we are really the amateurs, because we are a fairly low prevalence of TB country in the UK. It does vary, but it's not a common disease in the UK.
Prima, Gina, could I just apologize? I have to leave in 2 or 3 minutes for a memorial service for a friend. So I'm afraid there's one last question, then I'll have to go. I'm sorry. Yeah.
Okay. Thank you.
Okay, no more.
Okay. I will check the chat box. Maybe another question for you. I think the next question will be addressed to Dr. Simon. Thank you for your attending. Thank you for your time, and thank you for your support for our community.
Well, could I just say it's been a pleasure, and to thank you very much for inviting us. We are willing to work with you, as Gina knows, in any way we can to help you develop. I'm also working with other parts of Southeast Asia, with other member organizations in Southeast Asia. We're running 3 2-hour training sessions in the next month for those people, and Gina and I will talk about 2 people from Indonesia joining that training session as well. So let's grow our partnership now. Now we've started to be friends. It all happened through Twitter, with Gina and me through Twitter. So that's great. Good. Take care then. Bye-bye.
Bye.
Thank you. Bye-bye.
Thank you. Thank you, Steve Jones. Okay, let's continue with the next question. The next question is, how many types of fibrosis in this patient already diagnosed with autoimmune disease, which is Raynaud syndrome, and he wants to know about how many types of the lung fibrosis there are. Maybe Dr. Gina and Dr. Simon can answer this question.
Yeah, shall I start? I mean, yeah, I mean, some texts and some books will say that there are 200 types of interstitial lung disease or pulmonary fibrosis, but that's not true, really. What they're talking about there is all the various different inhaled triggers that can trigger something like hypersensitivity pneumonitis. So really the different types can be categorized into, you know, about 5 or 6 main types of pulmonary fibrosis, really. And I think the question was also linked to autoimmune disease, and certainly A number of autoimmune diseases are strongly linked with pulmonary fibrosis, some but not all of them. So rheumatoid, scleroderma, autoimmune myositis, mixed connective tissue disease, these would be the typical examples. And Raynaud's may be a feature of some of those conditions, but of course some people can have Raynaud's phenomenon without having any of those conditions. So again, it comes back to needing a good clinician to be able to put the diagnosis together, perhaps with some immunology blood tests to work out what the diagnosis is. Over to you, Gina.
Actually, here in Indonesia, most cases of ILD is CTD ILD that we have found before. Sometimes ILD is the first sign or symptoms that we found after SRCT performed, and then we check like autoimmune profile, and then we found it is related to CTD ILD. And but the problem here is most autoimmune tests should be performed in tertiary hospital, so it makes the diagnosis will be delayed. And the cost for this test is so expensive. Sometimes that's the problem why some patients cannot check. So it's the problem why the diagnosis will be delayed here. Actually, if all of the tests is complete in one hospital, maybe it will be more easier for patients to get the right diagnosis.
Yeah, so I completely agree, and I completely agree that some patients with a connective tissue disease will present as an interstitial lung disease as their first presentation. I completely agree with you. And it sounds like so there is an issue in Indonesia with access to CT scanning and with some of the immunological blood tests that would be helpful to make a diagnosis.
Yes, agree with you.
Okay, thank you Dr. Gina and Dr. Simon. Pertanyaan tadi berkaitan dengan berapa banyak jenis fibrosis paru yang ada, dan dari jawaban Dr. Simon, menurut textbook ada sekitar 200 lebih jenis dari fibrosis paru, namun yang benar-benar ada secara umum itu sekitar 5-6 jenis. Dan tadi tambahan dari Dr. Gina bahwa di Indonesia yang terbanyak itu karena berhubungan dengan penyakit jaringan ikat atau autoimun. Baik, we proceed to the next question. The next question is, here in Indonesia, most of pulmonary fibrosis cases that admitted in hospital were in severe condition, and in non-IPF cases with severe condition, and HRCT shows as extensive fibrotic lesion, could we prescribe antifibrotic directly? Please your comment, Dr. Simon and Dr. Gina.
It's difficult, isn't it? I mean, you know, the benefit of antifibrotic drug therapy is to slow the progression of the disease. It won't make it better. So in principle, we would like to start antifibrotic drug therapy as early as possible in the disease course before it's led to severe pulmonary fibrosis. That's a challenge. Even in the UK, that's a challenge, as Steve was hinting at, because we are not allowed to prescribe the antifibrotic drugs for IPF if their forced vital capacity is above 80% of predicted. That is, if they have mild disease. Yet the drugs still would slow the progression of the disease in those early patients. So there's a challenge there internationally, I think. If once a patient has, if a patient has very severe pulmonary fibrosis, and they may be unfortunately in the last year of their life, then generally we would avoid antifibrotic drug therapy in that situation and focus on, because there's not a lot to gain, and instead we would focus on symptom control. That would be our approach. How about you, Gina?
Actually, this is our questions here because patients were admitted to hospital with severe conditions, what the IPF or PF non-IPF. So for IPF, we maybe we can start antifibrotic wherever the stage is, but for non-IPF, that's the problem. Could we start with immunosuppressants or steroid, or we should start with antifibrotic, because this is the problem related to delayed diagnosis. So most patients come to hospital and we can diagnose with pulmonary fibrosis, but the staging is severe here at that moment. So it's a challenge, I think.
Any additional information, Dr. Simon?
No, I agree with that. I think what you're saying there, Gina, is that in people with an interstitial lung disease that's not IPF, there may be a component of inflammation, which may be partially reversible with anti-inflammatory therapy, as you suggest, with steroids or other immunosuppressants, and there may be a degree of fibrosis, and there may be a mixture of the two, and it can be challenging to work out how much potentially reversible disease there is. The fibrosis is not reversible, but some of the inflammatory component would be. So the principle of treating with steroids and immunosuppressants to see how much gain you can get, that would be, we would have the same approach as you. Yeah.
Thank you. Untuk pertanyaan terakhir tadi, bahwa bagaimana untuk kasus yang non-IPF dengan gambaran HRCT yang dengan kerusakan yang luas, apakah bisa diberikan antifibrotik secara langsung? Jadi menurut Dr. Simon tadi, prinsip dari pemberian antifibrosis adalah untuk menghentikan fibrosis yang terjadi dan diberikan pada kondisi yang dini. Dan tambahan dari Dr. Gina bahwa untuk yang non-IPF, tidak hanya disebabkan karena fibrosisnya saja, tapi bisa karena komponen yang lain, misalnya karena inflamasi, sehingga bisa diberikan obat jenis lain seperti steroid atau imunosupresan. Baik, we run out of our time, but there's a lot of question or still unanswered here. Maybe the last question. What is the indication and contraindication of lung transplant for PF patient? After transplantation, should antifibrotic be prescribed in this patient? Dr. Simon,
well,
your opinion, please.
The indications and contraindications for lung transplantation, I'm sure, vary from country to country. So I will tell you what the UK situation is, and then maybe Gina can tell us about the Indonesian situation. So in the UK, the main thing that stops our patients with pulmonary fibrosis getting a lung transplantation is age, because in the UK, you will not get a lung transplant over the age of 65. And yet we know for IPF, for example, the average age of patients presenting with IPF is into their 70s. So most patients are too old at the time that they present. And the reason that the restriction is on there on the basis of age in the UK is just limited number of donors, limited number of donor organs. So they have to pick patients who are going to do best. There are various other contraindications: weight too high, weight too low, osteoporosis, cardiovascular disease, etc. But age is the main thing that stops our patients with pulmonary fibrosis getting a transplant. And then there was a question about antifibrotic drug therapy after transplant. Is that right? I think if that was the question, the answer is no. We don't give antifibrotic therapy after a transplant. Gina.
Okay, actually in Indonesia, there is one hospital that can perform lung transplantation here. but there is no experience before. But they are now already received the patient who wants to get transplant. There is one donor for this, but they still wait for the recipient who eligible, who can get lung transplant, and they are want to get lung transplant. I hope in the future we can make more explanations or webinar related to this, because it's something new here. Although there is one center that can perform this. And for antifibrotic, I don't know, maybe because I don't have any experience about that.
Thank you, Dr. Simon dan Dr. Gina. Pertanyaan terakhir tadi berkaitan dengan transplantasi paru, apakah ada kontraindikasi dan indikasinya apa, dan kemudian apakah diperkenankan menggunakan obat antifibrotik pada pasien yang telah menerima transplantasi paru. Jadi menurut Dr. Simon tadi bergantung pada negaranya, ada ketentuan yang berbeda pada tiap-tiap negara. Untuk pengalaman di UK, ini bergantung pada umur. Usia di atas 56 tahun itu susah untuk dilakukan transplantasi. Kemudian masalah yang dihadapi di sana adalah jumlah donor yang terbatas. Kemudian untuk kontraindikasi di sini bisa berat badan lebih atau kurang, kemudian ada osteoporosis dan lain sebagainya. Dan untuk penggunaan antifibrotik tidak disarankan pada pasien yang telah mendapatkan transplantasi paru. Tambahan dari Dr. Gina tadi bahwa terdapat saat ini sudah ada pusat untuk transplantasi paru di Indonesia di Rumah Sakit Persahabatan, namun belum ada pengalaman untuk pasien dengan fibrosis paru yang mengalami transplantasi. Baik, we run out our time. Thank you, Dr. Simon, for your time, your support for our community, and it's
honor for us because you attend our launching day here today, and we are I on behalf of the organizer of Pulmonary Fibrosis Community say thank you very much, because we can discuss many things here today with you and get more knowledge about pulmonary fibrosis today.
It's been an absolute pleasure, and thank you very much for inviting me. And it's been a pleasure to be involved, and very interesting to hear comparisons and similarities and differences between the UK and Indonesia. And I would echo Steve Jones's words that, you know, onwards and upwards, and I will be very happy to help in the future in any way I can. Thank you very much.
Thank you very much.
Thank you very much. Baik, kita sudah sampai pada akhir acara. Terima kasih banyak bagi para partisipan yang sudah hadir memeriahkan acara pada sore hari ini, dan kami sangat mengharapkan partisipasi dari rekan-rekan untuk dapat bergabung ke komunitas bersama kami di Komunitas Fibrosis Paru Indonesia. Untuk dapat bergabung nanti mungkin bisa melihat kembali di sosial media kami atau di chat box sudah tercantum alamat untuk registrasi bagi para peserta yang berminat untuk bergabung di komunitas ini. We are now at the end of the session. Thank you very much for all the speakers, for all the participants. Maybe we can planning for our event in every 2 or 3 months for educate the people with pulmonary fibrosis. Thank you, Dr. Simon Hart. Thank you, Dr. Gina. Thank you, Mbak Jennifer, for your participation. Bye.
Good evening. Bye. Thank you, Simon. Terima kasih semua yang sudah berpartisipasi. Selamat malam.
Mungkin bisa dicantumkan untuk link registrasi member di kolom chat. Terima kasih semua untuk yang ingin mendaftar menjadi member agar mendapatkan informasi dan edukasi mengenai fibrosis paru bisa mendaftar di link komunitas yang ada di chat box. Terima kasih atas partisipasi Bapak Ibu semua.